Well, the appointed hour is here, so we'll get started. I'm sure some people will be filtering in. Feel free to continue to use the chat throughout this conversation as we keep moving. So as I mentioned a second ago, we'll ask you to type your questions and comments in the plenary. Feel free to do that. There also is something called a Zoom reaction button. So if you scroll down to that floating panel that arrives, you can see that there should be a way of giving some sort of reaction, as Abdon's demonstrating there, a thumbs up. So if you hear something that you agree with, or you want to encourage Professor Rupert or Dr. Sarah, feel free to use one of those reaction buttons. They might be able to see, and that can encourage them along the way. But we'll keep everyone on mute for this particular session. And definitely during the roundtables, the heart of our time will be speaking with one another, seeing each other's faces, and contributing, and really hopefully making our way towards solutions. As you saw, the name of this conference is Solutions for Comprehensive Cleft Care. So both documenting some of those key challenges we're all facing during the pandemic, but also pointing towards solutions. So definitely you'll have lots of opportunity to keep your mute off and keep your video on if you're able throughout this day. Thank you. So I would like to, first of all, just acknowledge the NGO sponsors. This conference is brought to you by the Circle of Cleft Professionals, which is an alliance of 10 international NGOs who are definitely in the cleft space and interested in comprehensive cleft care. We're grateful to all of them. Many have chosen also, in addition to being a moderator or a panelist, to help us on the support side, being a host or a scribe for today. And so we're grateful to this collaboration for supporting this conference and making it possible for us to bring all of you together today. If you're new to the Circle of Cleft Professionals, it really came about for three purposes. I mean, one, to say we really need to collaborate and network in order to do our jobs better. We want to share some of the impact that's happening in comprehensive cleft care around the world, and we want to try to be a support, especially to people working in low and middle income country contexts. And so that was really the rallying cry. And of course, this has even become more important as we get into the COVID era. So far, we've got 365 members in 58 countries. We've produced 18 webinars. There's a Slack discussion channel where we've been posting videos, and people have been advertising some of their opportunities to learn and grow. And then you can see even on the right-hand side of my screen, we've got some resources. And even out of today, we're hoping to populate some more resources to do with response to COVID, to do with hearing, oral health, multidisciplinary approach, all the things that make up a comprehensive cleft care approach. Those are some of the tools and resources that you'll be able to find on the cleftcircle.org website. So today, as I mentioned, over 160 people have applied and been accepted to this workshop. If you look, it's over 30 countries. You can see some of the places around the world that people are joining in from today, which is so exciting. And really at the heart of the Circle of Cleft Professionals, and indeed of the Solutions for Comprehensive Cleft Care Congress, has been the experience of people working in low and middle income country contexts, so LMIC. I mean, that's definitely been representative in the participant list. So this is something that is really encouraging, and we're so grateful to spend time getting to know one another, hearing from one another, and trying to build towards solutions together. We're grateful to our 6 advisors, who we'll thank a little bit later. We have 36 moderators and panelists who've been diligently preparing not only to understand the Kiko chat and Zoom environment, but also to bring some of their best thinking and questions about how to proceed during this pandemic together. And then, as I mentioned a few minutes ago, we do have 20 people who have been offered to be hosts or scribes to make sure that technologically this is as smooth an experience as possible. Even as we know many of you are dealing with difficulties in your context with internet connectivity and other challenges. So where did this conference come from? Well, we sent out a survey in May when we realized that this was probably more than just a temporary blip, that COVID was not only interrupting our travel plans, but was potentially going to have a long-term impact on our ability to implement comprehensive cleft care around the world. So out of this survey, we heard loud and clear that your ability in your context to reach patients, to support them, to provide treatment has been limited, and especially for those of us working in low and middle income country context. So we can see that most of us have said that the number of cleft patients being treated has decreased. This was already a couple months ago. I can imagine that this has only deepened as the pandemic has continued to unfold, and indeed even as many of our countries are experiencing a second wave even now. What that led to was definitely that sense that there is a large concern, a high degree of concern, both about the current implications and the future implications, and about our ability to support families with cleft. So that's where this conference came from. And really, as we reached out to many of you to say, what would you be interested in talking about? Basically, the top eight ideas that came out, those are the things that we've designed the roundtables around. So you'll see each of you has an opportunity to attend 2 roundtables today, one immediately following this plenary session, where you can choose one of 4 topics, and then one after that that's more disciplines focused. And in each of these has a moderator, has 2 or 3 panelists who've been diligently preparing. You're going to really appreciate the foundation that they're laying. And then we want to hear from everybody. What's your experience in your context? How can you move forward? What have you found that's working? And what are some of those intractable challenges that we need to address as a world cleft community to be able to move forward effectively? So that leads us to our plenary topic. To set that stage for our discussions today, we've called it Comprehensive Cleft Care in the Time of COVID. My name is Hugh Brewster. I'm the Executive Director of Transforming Faces. We're a Cleft NGO in Toronto, Canada, but I'm also here to represent the Circle of Cleft Professionals. And I couldn't be more delighted to introduce our first panelist. Her name is Professor Rupa Nagarajan. Many of you will have heard her. She's a long-term pioneer of comprehensive cleft care, especially to do with speech therapy in Chennai, India. She is the professor and chairperson at the Department of Speech, Language, and Hearing Sciences and an academic officer. Sri Ramachandra Institute of Higher Education and Research in Chennai. She's also served as the organizing secretary of the 13th International Cleft Congress in 2017, which was incidentally my introduction to the cleft world, was that conference, and what an amazing introduction it was. She's also the co-author of a book chapter titled Cleft Palate Speech in the Majority World, and she's a long-term leader in both the Smile Train and Transforming Faces comprehensive cleft care movements. So we're delighted to have her. If you have that reaction button, you want to try it out, please feel free to send along some positive greetings to Rupa. We can't hear the applause, but we can see it. And I'll pass right over to Professor Rupa for Solutions for Comprehensive Cleft Care. She's going to talk a little bit about looking back to look ahead. Professor Rupa.
Thank you, Hugh, for the very kind introduction. And I'm so grateful to Transforming Faces and the Circle of Cleft Professionals, indeed all of you, for giving me this opportunity to be a part of this unique conclave. I bring greetings. I bring warm greetings from Chennai, South India. I promise you it's very warm here. To all of you, to all participants, the charities, as we all navigate this pandemic together. I want to share with you this facade of this railway station in Chennai. That's a salute for all our frontline workers for their selfless, courageous, and non-stop services. We're really grateful to them. Next, Claire. I want to take a moment just to remember the very many loved ones who passed away too soon through this pandemic. And I think it touches our hearts, and we miss many, many of them. Next. The cleft community, cleft fraternity is bereft this year by the passing away of 3 champions of comprehensive cleft care. Dr. Jyotsna Murthy, as you know, a surgeon who was the president of the Cleft Conference, World Cleft Congress. Satish Kalra from Smile Train, who was absolutely responsible for so many cleft partner centers in India and indeed around the world. And Dr. Edenwala, a graceful, grand surgeon from India, whose wisdom was undoubted. These past 6 months have been very tough for all of us. I think we'll all agree that. And Dr. Edenwala's words, written at the presidential address of the Indian Cleft Congress way back in 2003, come to my mind. He spoke about Janus, the Roman mythological figure seen in entrances and gates representing the past and the future. Dr. Edenwala wrote, with one head, he looks back into the future and gives man the wisdom that comes from hindsight. And with the other, he looks into the future. And to the man who dares to walk fearlessly into the unknown, he gives courage that gives from foresight. I think all of you will agree we are in that time between the past and the future. Next. As you can see, this is just a a figure of COVID-19 daily cases from February to September, as you can see, every country has had its trajectory. And as far as India, you see on the top left, we haven't even reached a peak, while there are several other countries that are looking at a second wave. So the future yet remains unknown as far as this pandemic goes. In coping with the pandemic, low and middle income countries have additional challenges. Cleft care is completely or hugely dependent on charities or non-profit organizations. Comprehensive care is really not a reality in many places. They're also hardest hit economically, and therefore Cleft is not a priority. And persuading beneficiaries to come back is going to be a challenge. Next. Conferences such as this are really important because this platform allows us to hear voices from places most affected, listen to initiatives and coping strategies right from the grassroots. And together, we hope we can identify current best practices in the way forward. Yeah, next. Coming to our hospital, we started our services came to an abrupt stop on March 23rd. Our 1,500 bedded hospital became a COVID hospital, which meant nobody was able to access it. So all our services became online, including consultation and teaching. It's only in the last month, travel has been restricted and hopefully will allow patients to come back. But Chennai, my own city right now, is still averaging 1,000 patients a day. So we really don't know what's going to happen. And therefore, the lessons we learn from those in the curve ahead will be very important for us here in India. Next. So how do we manage cleft care during and beyond this pandemic? I'm sure guidelines provided by organizations, hospitals, and governments will be useful. And we are going to discuss several of these in the sessions that follow this. Next. So taking inspiration from the Cleft Plus workshops that were conducted by Transforming Faces over the last year, I would like to delve into some aspects of comprehensive care that could be affected by the pandemic. As we look ahead, what are our challenges and what are our big opportunities? Let's start with C for charities and nonprofits. We should be concerned if the sustainability of the service delivery models will be affected. What about costs and budgets? How will this be impacted in the near term and in the long term? Will fundraising be a challenge in the next few years? What about the backlog, and will priorities of some of these charities change? So the real question is that how do we plan for an uncertain future? And so many beneficiaries are dependent on continuous funding. I think this is something we all have to think about a lot. Locally, supporting care provided locally. What will happen to countries where the only access is the mission models? This pandemic could have a huge impact in those countries, especially as international travel is going to be affected. Will we see new models emerging that use different models? Maybe increased empowerment of local resources, maybe training parents for speech therapy, etc. I think there's a lot we are going to explore in this area. Education training. If any area there has been a paradigm shift in this pandemic, it's in online training and education. The cost and time related to travel has reduced dramatically, and training online over a period of time sustained has become possible. This could completely change the way we approach training in the future. There are limitations and barriers for online training, especially in skill development, but creative solutions are possible, and it's possible to improve the quality of existing training and identify efficient approaches for the development of new programs. Full inclusion is core to comprehensive care. And as we navigate and look ahead, how do we ensure full inclusion? Our beneficiaries face challenges even in the normal of situations. But how do we cope to the increasing socioeconomic divide, which has become more evident in the pandemic? The existing digital divide, the priorities of the families, community, and government. And I think most important, lockdown fatigue and mental health is impacting not just our beneficiaries, but all of us. And we will need to find some ways to address all of these. Technology is my pet subject. And in this, I think we have some great opportunities and some real challenges. Penetration of cheap mobile technology is a boon. It's helped us be connected with our families. In fact, that's almost all that we are doing today. But we have to remember that in most low and middle income countries, especially true in my area, any device, there is only one device in a family, which is usually a low-end mobile with poor connectivity, poor bandwidth, low memory, and not the best of cameras and mobiles. So how are we going to adapt our initiatives or techniques for training or therapy for such low-end mobile phones? One option we have tried is link a local roving, technologically savvy individual who can travel to parents who have poor resources and provide some kind of training that we can do. So really, what can we take back from this confluence? There is an opportunity. There is an opportunity for us to adapt and adopt from those who are ahead of the curve. We in India are really looking at it. We can re-examine what we have been doing, explore course corrections or an overhaul if necessary. I think work with our charities to redefine what are the needs on the ground in our areas. Identify a more efficient or better method of meeting the needs of individuals with cleft lip and palate. But I think we have to introspect, and I think we do a lot of it in this conference. If we cannot go back to what we were doing, what should we be doing in the future? I think that's something we have to think about. So as we seek wisdom from the past and we seek a vision for the future, we are going to reimagine, invent, innovate, rethink, adopt, explore, modify, adapt maybe. But we can draw inspiration from Tom Callahan, who said, the stronger the collective wisdom present, the stronger my sense of unique individuality. Only now it's within the context of the whole rather than separate from the whole. With these words, thank you so much for your attention, and I'm really grateful to all of you for being patiently listening to me. Thank you. I hope you have a good, productive hours ahead. Thank you.
Thank you, Professor Rupa. Wonderful. We really appreciate that large overview of some of the situation we're facing, as well as you've weaved in some of the challenges that you personally are experiencing in Chennai and beyond as the pandemic continues to wreak havoc within India and indeed around the world. For another perspective, I'm really delighted to also hear from Dr. Sarah Hodges, long-term medical director in Uganda. I'm familiar with her work at Korsu Hospital, just outside of Entebbe. And today, she's a consultant anesthetologist and deputy hospital CEO at Cure Philippines. So most of Sarah's work is with pediatric anesthesia with a special interest in the difficult airway. And then as medical director at Korsu, she led a team that included professionals providing comprehensive cleft care to children and families across Uganda. So we're delighted to have Dr. Sarah with us. And really, Sarah, I'll pass it over to you.
Thank you very much, Hugh. And thank you, Rupa, for that great starting overview. My focus will be very much more on the surgical side of things. Next slide. As Hugh said, I'm an anesthesiologist. Next slide, thanks, Hugh. I work at Cibo Cure Hospital in a place called Davao City in the Philippines. It's a disability hospital and specializes in orthopedic and plastic reconstructive surgery, with a focus mainly on children. And our cleft work is heavily supported by SmartTrain. As Hugh mentioned, I've been involved in cleft work since 1995 when I was working in Uganda, and I worked there for over 20 years. And in fact, I've only recently moved to the Philippines in January of this year. And I have to say, it's completely the wrong time. Can you go back a slide, please? Sorry, yeah. It's completely the wrong time to move to a new country. But anyway, that's just how it is. So in the next few slides, I'm going to try and share some of the lessons we learned when we tried to restart elective surgery during this COVID-19 pandemic. So we all know that on the 30th of January, the WHO declared a public health emergency, which was upgraded to a pandemic on the 11th of March. And effectively, all elective surgery, such as cleft surgery, was put on hold because hospitals had to battle with the influx of patients infected with SARS-CoV-2 virus. In many places, theatres had to be reassigned as ICUs to support, accommodate patients with severe respiratory symptoms requiring critical care support. I have the actual privilege of working in a purely elective hospital, so we never had to face that issue, although our Department of Health asked us to put in place contingency plans in case the local government hospital was overrun with COVID-19 patients. And at one time, when we completely stopped all surgery, we did have one floor completely taken over by medical staff from the government hospital who were actually having trouble finding accommodation because many of their neighbours didn't want them around. They were being ousted because they were frontline workers. Our city was put under what was called enhanced community quarantine, but actually it felt very much like house arrest. And we had a 12-hour curfew. We had restricted movement out of the house. We had to have a special food and medicine pass, and you could only shop on certain days of the week. Travel was restricted, and all children had to be confined to the home. They weren't allowed out. They couldn't play in parks or gardens or anything like that. So of course, you know, going to and from hospital was impossible. You know, children would fall off swings, break their arms, nothing would get done about it. And certainly for children with clefts, that was really definitely at the bottom of the pile. Next slide, please. Suddenly, the virus seemed to be moving very fast across the globe. And initially, there seemed to be very little knowledge, but a whole lot of fear. And this fear was definitely amplified by the media, because there seemed to always be a huge emphasis on case fatality rates. And that is such an unhelpful number in the midst of a pandemic, because it varies day to day. It's not a number that you can associate with as an individual, but everybody focused on it. And certainly where we were, people were incredibly fearful. And also across the world, different countries' responses varied, and guidelines seemed to change daily. Wear a mask? No, don't wear a mask. Is it aerosol? Is it droplet spread? Is it infectious for what, 2 days, 5 days, 7 days, 14 days? And so it went on. And so you're kind of battling with this lack of knowledge into how to move forward. But one of the really good things, and Rupert talked about this, that came out of this was the sharing of information. And there were so many websites, there were so many groups, there were so many webinars. There was a huge readiness to share information across the globe. And I mean, papers were being published on a weekly basis. It was just quite incredible. And we realized that as a hospital, as an organization, we had to be really well informed, but also remain agile and flexible so that we could adjust our guidelines as new information became. Next slide, please. Our University of the Philippines and our Department of Health, but also I looked very much to the UK and the US, and some very helpful documents came out on how to restart elective surgery, both from the American College of Surgeons and the Association and Royal College of Anaesthetists in the UK. The first thing they talked about was ensuring a sustained reduction in the rate of new COVID-19 cases. And that was actually quite difficult because things sort of change from day to day. And as Rupert pointed out, India hasn't even reached its peak yet, and other countries are now going through a second wave. So how long do we, and how much of a sustained reduction do we wait for? How long do people requiring elective surgery have to wait before we restart? So that I found was a difficult one. So in fact, we restarted elective surgery when the cases were flattening out, but there wasn't really a sustained reduction. And the first thing that these documents talked about was having sufficient space, because in some places, operating theatres had been reassigned as ICUs, and those had to be then changed back to being theatres again. They had to be cleaned out, they had to be disinfected. And do you have sufficient elective beds to take elective patients? Can you separate your infected and non-infected patients within the hospital? Have you got only one entrance? Can you separate the way in? Have you got different outpatients? Have you got different places to assess them? That whole thing is very, very tricky when you're taking COVID as well as non-COVID patients. Then also looking at the staff. Have your staff been trained in the use of PPE? You know, have we actually tried to put on an all-in-one suit and take it off without decontaminating ourselves? Do you actually have enough staff available? Have they been worn out by taking care of COVID patients? Are they exhausted? Do you have infected staff? How can you manage to sustain elective work with the few staff that you have? And then stuff, I was thinking more about equipment. Do you have enough PPE? For example, for me as an anesthesiologist, we use on our breathing circuit something called HME filters, and these filters humidify but also filter out viruses. And suddenly we were having to use two of these, one on the expiratory port and one on the patient. And actually, I suddenly found I couldn't get any in Davao for little tiny babies. I could only get adult ones. That makes it really difficult when you're trying to anesthetize a little tiny baby. So do you have enough equipment? Do you have enough disposable equipment? Can you clean it? Can you reuse it? And this is where there were so many organizations that were incredibly helpful, like N95 Decon were giving lots of help on how to reuse PPE when you couldn't get enough of the equipment that you needed. And the final thing, systems. Now, this is actually really important because we're overloaded with information, we're overloaded with incorrect information, often from the media, and you're trying to ask your staff to come to work and go through the day-to-day. And it was really important to have absolute clarity in our systems so that they could do their day-to-day work. We needed good policies and procedures for infection control and prevention, preservation of our PPE, and also for scheduling of patients. You can't just suddenly have a complete walk-in and allow 50 patients to walk into a small outpatient department. You had to reduce the numbers, have appointments. We had systems where everybody had a temperature checked as they came into the hospital. They had to clean their feet, they had to wash their hands. They went through a health declaration form, everything like that, which slows everything down. So you had to really rethink how you did your day-to-day work all the time. As I said, I'm very fortunate. I don't work in a general hospital, so some of these issues with regards to space and staff didn't apply. But we put in place a number of procedures, basic temperature checking. Anybody who approached the hospital had one of those guns, temperature guns pointed at them. So all staff, patients and visitors to the hospital. Mandatory mask wearing. And now also we have to wear a face shield, especially when we go out to the shops, we have to wear a face shield as well. And in the hospital, we're also wearing masks and face shields as well. All patients coming to clinic have to answer a set of questions and complete a health declaration form before they're even allowed in the hospital. And now, 72 hours prior to surgery, all patients have a PCR test. And any positive patient is referred to the city health authorities and their surgery postponed. This has enabled us to increase our safety, but it is unfortunate if then somebody gets cancelled because then they have to have their PCR test again. Yeah, next slide, thanks, Hugh. So what would my recommendations be for people thinking of restarting surgery? Because when you look, a few months ago, when you looked at all the documents for restarting elective surgery, Cleft surgery came very much at the bottom of the pile. But there is a certain urgency to cleft surgery, notably certainly for palate surgery, for those who are going to learn to speak. And you can't keep deferring it. You know, how long are you going to wait? A year, 2 years, 3 years, and then you've missed the boat. So I think that we have to really think about prioritizing certain cleft surgeries, definitely. My first recommendation would be stay informed. There are so many global forums which are sharing vast amounts of helpful information to guide our decision making. It's also good to use your local Department of Health to also guide your processes. And make sure you have really, really clear policies and procedure that everyone is aware of, and that you have regular staff education. We had a presentation for our staff. We played it many, many times. We talked them through it many, many times, just to try and avoid all that media hype and give people real information and keep them up to date with what's going on. Next slide, thanks. Now, your staff are your biggest asset. So you really need to keep them safe. And you need to be put in place systems that mean that they're happy to work. I think you have to be very aware of the cognitive overload, and you can become quite exhausted at the end of what seems like a really short operating list. Routine tasks take longer, they've become more complex. It's longer between cases because you have to clean out the theatre. And that means only think about increasing your cases, your numbers slowly, so that staff get used to working with the new normal. Don't try and rush forward and think, we'll do loads, we'll get rid of our backlog. Take it one step at a time. And when you're using a new piece of equipment for the first time, try and do a practice run first so that everyone knows what to do. As an anesthesiologist, I intubate all these cleft patients, and initially I was doing it through a Perspex box. Now I've got sort of like a Perspex shield, and it was really important to practice with the nurse, and knowing what level to have the table at, where to put the plastic sheet, where to put my hands, where to put the equipment, and just run through it so that it doesn't come as a surprise when you're doing it. But I have to say, for a task that I have done, I don't know how many thousands of times, it's really hard work at the moment. You have an N95, you have a face shield, you're double gloved, you have a gown, have this Perspex shield, a plastic bag, and you can't really see properly. It just everything just becomes a whole lot harder. So I think be aware of that so that you look after your staff properly and don't overload them. Next slide, please. It's really important to be aware that people have very different levels of fear. Not only personal fear, where we are in the Philippines, and it was also the same in Uganda, many people live in multi-generational households. So although they may not be too worried about themselves if they're in their 20s, they may be very concerned about their grandmother or their elderly mother with asthma or their father with hypertension that they're going home to. And so there is an added level of fear, not just for themselves, but also for the people they're sharing their homes with. And loneliness and isolation are also common. Sometimes neighbors will distance themselves from you if they know you're a health worker, or they may terminate your rent agreement, and then you're actually homeless. People don't want to deliver food to you. People don't want to come to your house. You feel like you've got the mark of Cain on your head, and you're a soiled person, and it can make people feel very, very isolated, and that adds another level of stress when they're actually coming to work. And I think as certainly within management, you have to be aware of that and support your staff. We really need to, next slide, please. As I said, start slowly. It's much easier to increase than to reduce numbers, and have regular times of feedback, so that checking in on everyone, so that everybody knows they're okay, and are your staff coping? Do we need to step back a bit? Can we go on? How's it going? Mental health. Look out for one another. Check in on each other. We are effectively societal beings. We do things together. We do things as work, as groups. We work together. We socialize. We do leisure activities together. We play games in teams. We go out to dinner with friends. And suddenly our whole society has been threatened by this unseen virus, and all the measures that are put in place to protect our society and ourselves as individuals are very, very isolating. We wear a mask, so we can't see someone smile. We now also wear face shields, so you don't see somebody particularly well. We stand 2 meters apart, so you don't actually chat to somebody in the supermarket queue anymore. You can no longer shake hands. You can't give a colleague a reassuring hug. All that is frowned upon. And all these important and necessary measures are actually distancing us from one another just when we need the support. And I feel strongly that this term that we use, social distancing, which comes up all the time, actually should be changed to physical distancing, because we really, really need to be socially supporting one another, not socially distancing ourselves. And small acts of kindness and support can go a really long way to help our staff continue amidst these fears and these restrictions. So I just want to say thank you very much. And I just want to leave you with go slow, really support your staff, and have clear policies. I would say that is the way to go forward. Thank you very much.
Thank you, Dr. Sarah. Wow. Very helpful from Professor Rupa, overview globally of what's been happening, and then really getting into the nitty gritty, Dr. Sarah, of leading a team, intubating cleft infants, and as well as the social element and mental health element of the COVID that's really, we must acknowledge at this point in this conference, is affecting each one of us, and some of us even affecting even more. Some of us on this call, I know, are mourning a parent or a relative who's died during the COVID period and haven't been able to mourn properly. Some of us have been forced to work from home. Some of us haven't been able to work at all. So I really appreciate, Dr. Sarah, how you've acknowledged some of these other challenges beyond just the technical procedures of how we move forward with comprehensive cleft care during the pandemic. This does bring us to the end of our plenary session. And if you'll see throughout the day, our hope, and I think our two panelists have done an amazing job of doing this, of laying a foundation. And you'll see throughout the chat, different questions that will be picked up by, maybe picked up by the Outreach to Vulnerable Families Roundtable, maybe picked up by the Way Forward for Safe and Timely Repair Surgeries, picked up by how to care for yourself and your team. So we've covered all the bases here. We're not going to be able to talk about all this all together in the plenary, but that is exactly what the roundtables were designed for. So continue, please. If you're a moderator, you can look through. I see Dr. Ayala Ruben has been watching this. Take some of the comments here, bring them into your roundtable, and we'll hopefully emerge with a really clear picture of what's happening in each of our contexts and identifying some of these ways forward, like Dr. Sarah and Professor Rupa have identified for us today. So from here, we'll be going into a break. After the break, in just about 10 minutes time, please be on time to go to your roundtable number 1. If you're a panelist or a moderator for Roundtable 1, you don't have a break. I'm sorry. Go directly to that room on Kiko Chat, engage the Zoom, and get ready. So we make sure we're ready to start in 10 minutes, which is 12:50 GMT. And then we'll go from there to a second break, a roundtable, and again, more discipline specific after that. And finally, we'll all meet together here at 15:40 GMT for a closing plenary with Dr. Felicity Mehendale. So you won't want to miss that as well. So just in case you've forgotten how to do that, you've successfully navigated, first of all, by getting here. Congratulations. You've clicked on the top left-hand corner, that join video. You'll do the same thing now. So We'll leave the meeting. We'll close the meeting in just 30 seconds or so. You'll be back onto your Kiko chat environment. Feel free to take a break or look through the different elements. Put comments or questions that you would like to see some of these roundtables engaged with. Answer someone else's questions or add a comment of your own. This Kiko chat is meant to be as interactive as possible, to hear from as many voices as possible, so that we can truly come up with some solutions that can apply to all of us, or at least that we can take forward in different ways in all of our contexts. So you'll see there, top left-hand corner, when you get into Kiko chat, just how you got here. You'll do that in your next roundtable. Please choose the one that is most applicable to you. And then we ask that once you're in that one roundtable, it is only 75 minutes long. So we'll ask you to stay put. So once you get in there, be part of the conversation, listen to the panelists, and then you'll be able to see one another and really talk through these issues and how you can take it forward. So thank you very much. We'll now have a quick break. We'll be back at 8:50 a.m. in Toronto, just going to check my time here, 12:50 GMT. Please choose a roundtable, stick with it. Remember the green button, and feel free to grab a coffee, stretch your legs, or even go to the coffee break room. If you see an old colleague you haven't seen for a while, down at the very bottom of the rooms, you'll see there's a coffee break room. You can click the Zoom there and have a quick conversation. Thank you again to our panelists. We'll see you all together again for our closing panel. Don't miss that. And thank you for making time today. We're off to a wonderful start. Bye, everybody.